So let's start with Dr. Ramesh Adiraju. He's going to be talking about limb salvage in complex PAD made simple.
So hi, it's nice to be part of APVIC again. I've kind of missed the last few years. So Dr. Khanna, thanks for having me involved at the 13th APVIC. My topic today is critical limb ischemia management made simple. I'd like to start with the outset to see what comprises complex PAD. Usually fibrocalcific disease, systemic vascular inflammation, diffuse multi-level involvement is what makes it harder to decide how to best manage these patients, because they usually, whether you go endovascular or surgical, these patients have complex disease and suboptimal outcomes, procedural complications, recurrent procedures, challenging anatomy, particularly calcified disease, is what makes it harder to manage these patients and keep them revascularized for a long term. So I decided to present this as a complex disease, PAD management made simple. There's two aspects to it: non-invasive and then interventional measures to make the procedure and their management simple. I believe non-invasive, Dr. Khanna knows I've been passionate about dysautonomia in vascular medicine and cardiovascular disease. We have protocols for this, which I will get to in a little bit. Mainly, dysautonomia regulation is to approach and achieve endothelial stabilization, address systemic vascular inflammation, novel risk factor intervention, which is diabetic systemic vascular disease management, improve microvascular dysfunction, which is what causes these patients to have distal complications that cause limb loss and critical limb ischemia. We have to often address peripheral venous hypertension and insufficiency, which is not commonly thought of, including peripheral arterial capillary function improvement when you manage these patients for long term. Interventional, in addition to the balloons and stents and atherectomy, this is one of the systems that I have helped to develop along with an endocrinologist about 20 years ago. That is called the end-diastolic pneumatic compression treatments that helps with the angiogenesis and distal disease management after proximal revascularization. The simpler, newer measures on the horizon have been the drug-coated balloons, as we all know. Shockwave balloon treatment, this is the focus of my presentation today, which we'll discuss. Mergen is a wound healing bioactive glass polymer that we've been using along with the end-diastolic compression to really help angiogenesis and distal disease management in these patients, which is a non-invasive intervention. Basically, looking at calcified disease, the calcium buildup is primarily due to vascular inflammation, and it's deeper. A lot of the devices and interventional techniques we have, including balloons and atherectomy, they don't address the deeper calcium. And when we try to push our luck, it actually results with a lot of complications. You have distal embolization, vascular injury to the soft tissue, which precipitates fibrosis, reinterventions from progressive recurrence of disease and loss of side branches and this kind of stuff that makes it complicated to manage these patients. Lithotripsy is a 30-year-old technique used in medicine, primarily developed for kidney stones. Recently, there's been a resurgence of intravascular lithotherapy, which is what I'm going to try to discuss about. It's basically, IVL is a system that's developed to deliver electrical energy that creates steam bubbles within a closed liquid environment. Here is a demonstration of what exactly happens. The bubbles then create shock waves, and it helps modify. Hello? So this is a picture demonstration.
3 kilovolts of energy that travels through the connector cable and catheter to the lithotripsy emitters once per second. While other treatments can't differentiate between calcium and soft tissue, acoustic pressure waves pass through soft tissue to impact both intimal and medial calcium. When the waves impact the calcium at nearly 50 atmospheres, the vessel becomes more compliant.
So that's a demonstration of the system. It's a very compatible balloon. Goes over 014, there are 035 systems too. It's easily maneuverable, reaches different distal disease and tight locations pretty effectively. So this is what the shock wave does. It breaks up the hard calcium due to the energy created, mainly pulsatile. As you can see in the side demonstration, doesn't affect the soft tissue. So the vascular injury, fibrosis, or creating acute thrombosis because of soft tissue injury, these kind of complications, endothelial disruption is minimal with this technique. With that background, I'd like to present a case. As you can see, this is a 72-year-old previous history of a tissue aortic valve replacement, peripheral arterial disease. A couple of years ago, he had a right popliteal stent and had restenosis of that, which is when he presented to me as a second opinion. We did a primary debulking atherectomy for that. And then 2 years later, he came back with left claudication. As you can see, is high CRP with a normal cholesterol and high triglycerides. This is the typical vascular inflammatory patient, not our run-of-the-mill cholesterol vascular disease. His ABIs are there. Left side is pretty critical. And as you can see in the cine, there's pretty calcified distal SFA popliteal disease and another critical stenosis of the tibioperitoneal trunk. Here's a demonstration of the significance of that calcium. This is an 014 guide wire that kind of buckles there, which is how severe the stenosis is. This is the kind of vessel where atherectomy could be difficult for device delivery. There's a higher risk of long dissections requiring multiple stents, extending the procedure when you go with the balloon stenting, and higher also risk for acute thrombosis, distal embolization. That's kind of a complex situation that can evolve in the labs when we work with these patients. Here's a demonstration on the left of the shockwave balloon that was able to easily pass across. By the way, the knuckle wire technique that we use to cross the lesion, I usually use a balloon support to push the knuckle. that actually works very well with them, especially with 014 wires. We had 3 courses of local shockwave pulsation, and as you can see, it opens up nicely. Here's an angiogram post-shock wave of the popliteal. And then we went down to attack the tibioperoneal trunk. That is a small 3O cutting balloon. Here's the result after cutting balloon angioplasty. As you can see, there's a severe stenosis still with a chunk of calcium. That's going to be hard to manage if you balloon dilate or even atherectomize. There's a high risk of it losing the side branch. We then did shockwave treatment of that. As you can see, the initial treatments is residual stenosis, which then opens up nicely. Here's a final angiogram. It's a little bit of delay there. The side branch is preserved, has a good runoff distal vessel. So that's how shockwave makes this calcified multi-level disease simpler to manage in the lab. And it's a faster procedure, decreases radiation exposure, dye utilization, etc. I just want to briefly go over what I meant by dysautonomia management. Here's a demonstration of endothelial structure on the side where endothelial integrity, whether it's working as a barrier or as an absorptive organ, endothelium, vascular endothelium, I believe is an organ by itself. There's local hormones, cyclic GMP and nitric oxide pathway to maintain vascular integrity and function, and PDGF, VEGF type of local hormones that are released by endothelium, which maintain distal capillary function and integrity. I believe this is a function of the autonomic system to maintain integrity of the endothelium, because these gap junctions are smooth muscles that are regulated by controlled input of the SNS and PSLs. Here's a schematic of autonomic nervous system dysfunction that can affect the endothelial function, metabolism, insulin resistance, hypertriglyceridemia, coagulopathy due to multiple factors, which I don't want to get into detail for this talk, eventually leads to diffuse vasculopathy, systemic vascular inflammation, hypercoagulable state. This is why, if you have to imagine, anybody remembers, this is like trying to manage these factors one by one or multiple different approaches, you will be missing the target and lose the battle. So our approach has been to try and address the bottom line, which is autonomic dysfunction, to try and reset these pathways to prevent vascular inflammation causing distal disease and eventually amputations. Here's a schematic of what I had developed. The central clinical autonomic loop that's predominantly regulated by the hypothalamic vagal axis. This is the gigantocellular formation at the nucleus, at the substantia nigra. That's the central vagal nucleus, which has a feedback with the hypothalamus and regulates this slew of nuclei at the brainstem, which determines the parasympathetic output and the sympatho-parasympathetic balance. Here is the peripheral arterial and venous capillary integrity that's a function of the autonomic system. This is a schematic of various pharmacologic interventions we have done at different levels to try and manage these patients. End-diastolic pneumatic compression treatment impacts the arterial and venous peripheral capillary integrity, thereby balancing this SNS and PNS activity, which is how autonomic regulation is done. Mergen, as I mentioned, is a bioactive glass polymer that's new on the horizon that we've been using along with the end-diastolic compression to treat our patients after proximal revascularization. They go on the EDPC treatment, sometimes if necessary, if they're non-healing wounds, that we add Mergen. This also helps with the local hormones and angiogenesis. So that's how we basically have a protocol of arterial revascularization with minimal endothelial damage and venous distortion through shockwave intravascular lithotripsy, which is a new dimension to revascularization with the minimal endothelial disruption and vascular soft tissue injury, which then, as we all know, results with all these complications down the road. Autonomic regulation is important for long-term patency of proximal disease and improving angiogenesis and distal disease evolution through various factors. Peripheral venous tone is a often forgotten entity which actually reflects on the arterial integrity and autonomic system balance. Mergen is a new non-invasive addition to our protocol, as I mentioned, that works with the end-diastolic compression. End-diastolic compression approach basically helps maintain the arterial venous capillary bed and improve peripheral arterial integrity and reduce peripheral venous hypertension, which is the underlying cause for most of these chronic ulcers, venous stasis disease. Venous return is enhanced, local hormones are regulated, free radical clearance is intensified, neorevascularization is triggered through positive feedback. Autonomic system regulation is also indirectly helped with this system. It not just works mechanically, it works through a lot of local vascular homeostasis, as I mentioned. So that's basically complex vascular disease management made simple. I'll take any questions. Dr. Khanna? Dr. Ashokan? You
Yeah,
were muted, so I couldn't hear you.
Yeah. Hello? Can you hear me?
Yes, now I can.
Yeah. Dr. Ramesh, excellent talk. You covered most of the things, and the newer things what you are introducing is the this calcified lesion, that how to tackle patient with extensive atherosclerosis. And the newer things what you are discussing is the drug usage in this situation. There is a Mergen with end-diastolic compression. I think you covered a lot and extensively, and the new concept also. And I think anybody would like to discuss further and add any points to this? And what about focal lesion? What is your approach? And do you go by the task classification for treating this disease? Or do you advise this one the early stage or late stage? What's your approach in this? Because this is a new concept.
You mean for focal proximal disease?
Yeah.
Yeah.
So whether proximal or even if it's not very extensive, what's your approach? with this Marachen?
Focal proximal, yeah, Meragen is mainly for after proximal revascularization.
Yeah.
Instead of getting into distal disease, which is usually time consuming and a suboptimal outcome for long term.
Yes. Okay.
These patients, after you deal with the proximal disease, you just then have them on the EDPC Meragen non-invasive protocol to try develop angiogenesis and stabilize the distal disease.
Dr. Ashokan, I got a call from Dr. Khanna. He has had a case to attend to. But he's asked us to continue with the presentations because we're running behind schedule.
Yeah. So who's the next presentation? Somebody should
I think it's your talk.
Because I don't have a job. So, but Ramesh, excellent talk. Because of the time paucity, we have to go into the next session. Next is my talk. So thank you.
You're welcome. Thank you for the...
Can I share my screen?